Again, thank you to all of our speakers today. It was great to hear about all the aspects of critical care management in acute flaccid myelitis. There are several questions that came, but I will start with a basic question that we are always dealing with, and is the patient is in the emergency department. The patient is somewhat relatively stable with some weakness, perhaps at the early stage of quadriparesis. So the main question for Jessica and Becky is obviously the conversation between the emergency department staff and the neurologist as well as the intensivist is critical. So briefly, so what are the major clues that both of you as intensivists will give to the emergency department specialist? And when and what are the clues that that patient that is in the emergency department needs to be admitted to the intensive care unit or can be admitted to the regular bed under supervision? So what are the clues for that decision? Jessica?
Okay, I can start. I think first and foremost, I think it depends on the institution that you're at and what services are available to you. So do you have a neurologist in-house? Do you have rapid access to MRI? So there's a lot of variability there. And I think that whenever you can get a neurologist to do the exam in person, that's always really helpful because they may have a little bit more of an expertise in performing an exam that may pull out some of those things that we talked about, like bulbar weakness and things. And then in centers where you can get an MRI from the ED, that's always, of course, very helpful. I suspect that's probably not most centers. So then you really want to ask some pointed questions. You want to hear what they're saying, but you also want to ask them, are you seeing the child has a soft voice? Are they able to count to 20 on one breath? Are they able to cough for you? Do they seem like they're drooling? I think it's good to ask them very specific questions that talk about bulbar weakness and also what is their lung capacity? How can they demonstrate that at the bedside?
Yeah, and I think that I would just add early on, the weakness that you're seeing, assume that it's just going to progressively get worse over the next 24 hours. Now, it might not, but I think working with the assumption with whatever weakness you're seeing, it's going to get worse. Now, if it's an isolated limb that's paralyzed or the child's having difficulty walking, but they have a good, strong respiratory drive, cough, gag, can lift their arms up and, have good mobility of their upper extremities and really aren't showing signs of, the cranial nerve involvement or the high cervical spinal cord involvement. I think that that's a big difference as well. But then also looking at the support that you have on the floor. But they're showing any signs of high cervical spinal cord or brainstem involvement and are showing signs of respiratory weakness or bulbar compromise. I would have a really low threshold to send those kids to the intensive care unit for at least, the first 24 hours, just to make sure that they don't, progressively suffer a significant respiratory failure.
I think I would add
Thank you, Becky.
Sorry.
Go ahead, please.
I was just going to add that, encephalopathy really isn't part of AFM, but we do see kids that are encephalopathic. And I think when the ED calls and has a child that sounds like AFM and then they describe a child that's sleepy or is lethargic, that you really want to think in the back of your head that might be a patient that's hypercarbic and therefore really should come to the ICU for proper evaluation. Function.
Thank you so much. Leslie, since you are the consulting pediatric neurologist and frequently you are asked to come to the emergency department and give your opinion, what are the clues that you are providing the emergency department or the pediatricians about the need for bringing the patient to intensive care unit or just sending the patient to the regular floor?
I think I probably have an odd perspective coming from Boston Children's in the sense that we have a lot of resources. So on our neurology floor, we can get NIFs and vital capacity, some of that monitoring, which most places wouldn't be able to do. But if there's any concern that the patient is having bulbar dysfunction early in the disease, not got a good mental status and alert and able to really give you a good, single breath count, all of those things are usually the first things that we're looking at while they're down in the ER.
Great, thank you so much. There are a couple of questions that are directed to the intensive care unit, and I think that the use for sedation is very critical. But there is one question from Keiko, who is asking about how much experience do you have with the use of ketamine, particularly related to the amount of secretions for people that require, for patients that requiring good pulmonary toilet. And if you have tried NAVA, NAVA for respiratory support, invasive or no invasive.
Yeah, those are excellent points. Absolutely. When you're administering ketamine for procedural sedation, you have to anticipate that you're going to cause increased secretions in those patients. So you can balance it with, other agents that'll block that response. But the reality is you have good suctioning, and you do definitely need to be prepared for that. The nice thing is the increased secretions with the ketamine boluses are very short-lived, and as long as you're prepared to help them deal with that. But it is weighing the risk benefits. The ketamine is great in this situation in that it doesn't suppress the respiratory drive. It's hemodynamically the most tolerated procedural sedating agent. But yes, secretions are an issue, and you got to keep your patients safe with those. But I think good preparation, you can work with secretions, given that it is such a short time period that the secretions really are increased. Now, with long-term sedatives, if you're putting them on an infusion, we would highly recommend not putting on a continuous infusion of ketamine, just using that for intermittent sedation. And then you asked about NAVA ventilation. So I have no experience using NAVA ventilation with these children, and so it's hard to speak about since I don't. I would be hesitant to think that it would be very effective, because my understanding, at least, that with NAVA ventilation, the patient actually has to synchronize to a degree with the ventilator, and I would worry that these children are too weak to actually trigger the synchrony needed to get a supported breath with that. So I think that would be my hesitation, but I personally don't have any experience with that. But I do know, even with trying to get these children to sync up in SIMV mode through providing BiPAP through synchronized ventilation, a lot of times they're just too weak to trigger the machine, to trigger the breath. So unfortunately, it's very hard, non-invasively, to synchronize with these children because they're so profoundly weak.
Becky, Jessica, any other comment in addition to Becky?
No, I think I agree. I mean, I would strongly agree that ketamine should not be used for these patients for continuous infusion. It's probably best used for the intubation.
Great. Now I have the $1 million question for Leslie. Every patient that comes with myelitis to the emergency department or to the intensive care unit, everybody asks the question, can we give IV methylprednisolone or Solumedrol? You already explained very well, but do you mind to emphasize what is the answer that you have in your place about that question?
It's an impossible question because we don't really know. We know it kills a mouse. We know we've given it to patients and we don't see them turn the corner. I think we have the theory that giving steroids to somebody who has an infection is going to harm their ability to fight off that infection. I have my own anecdotes before I stopped using steroids where I've seen patients turn the corner, but I think that is targeting secondary inflammation, and I do everything I can to avoid giving them steroids in the early acute phase of illness. Is that clear enough, Carlos?
I think so. I think that, again, that is, as I always use the term, the $1 million question, because it's very challenging for the physicians taking care of these patients just to make the decision when to move on a specific treatment. And I think that you outlined those very well. Great. One thing that is a very difficult conversation with the family when the patient is in the intensive care unit, and I have crossed with this situation and several opportunities, is the decision about tracheostomy. There are several participants in this symposium that are basically family members, but there are also some primary care providers and pediatricians. Do you mind giving the most important clues about when we need to move to tracheostomy, or when we are able to procrastinate a little bit on tracheostomy, and when definitely we'll say this patient doesn't need tracheostomy? Do you mind to go to those important clues?
Yeah, so I think the patient that you can feel very confident in saying just needs a tracheostomy and probably an early tracheostomy are the ones with significant high cervical spinal cord in the C3, 4, 5, and or brainstem involvement. The children who don't have a strong cough or gag at all, the children who have lost the ability to speak, the kids that are just so profoundly weak that with removing the breathing tube, they just would not be able to maintain. So if you don't have a strong cough and gag, you don't have good tongue control, you need a tracheostomy at least early on. The children that are hard to decide whether they need a tracheostomy or not are the ones who have a cough and gag, but maybe it's just a weak cough and gag. The children who will maintain themselves in the UMV mode of ventilation for 24 hours and then tire out after that. There are a lot of kids that we try to exercise and provide pulmonary rehab in the ICU to try to prevent the tracheostomy because they're these borderline children. But with AFM, you really have to weigh the risk benefit of that. Like maybe if we keep them in the ICU for a month, they can leave without a tracheostomy, but that's a month of inpatient rehab that they may have missed out upon. So I think you really have to weigh the risk benefits of getting kids to early rehab versus keeping them kind of trapped in the ICU trying to decide if they need a tracheostomy or not. And if you have a good rehab center, I would really opt to, if you're questioning at all, early tracheostomy. It'll help support them in rehab. It'll get them through all their exercises, and it'll support them and keep them safe. If you're questioning too whether they need a tracheostomy or not, I would just hate to not put a tracheostomy in a child and have them suffer a significant hypoxic insult that'll injure their brain. AFM doesn't injure the brain, as much as it does the spinal cord. And so I think this is one of the few times that we're more conservative with tracheostomy, because you just don't want to be wrong and have the child suffer permanent brain damage because of that. Whereas a temporary tracheostomy that they may need for a month or 2 months or 3 months will keep them safe and help support their rehab abilities better.
I think I could add to that one thing, which is that respiratory failure is usually the only reason that kids are in the ICU. So we don't, unlike other disorders where they may need hemodynamic support, and there may be lots of reasons why a kid still needs to be in the ICU, it's not just the ventilation piece. Often for AFM kids, they're just only in the ICU for that sole reason. So if they had a secure airway, they would be able to go to rehab. So we really want to take into consideration how long are they not able to rehab, and especially for kids that can't be mobilized because the airway is not safe because of their age or their cooperation level. How long do you want to keep someone in a bed when the sole reason that they can't leave and be rehabbed is because of this airway issue?
Great. Thank you very much. There is one issue that probably is important, and is our nightmare when we bring patients to the intensive care unit, and is the risk of infection. And particularly, some of these patients are in a high risk of acquiring secondary respiratory infections. And at least in many circumstances, in some neurological patients, we avoid some specific antibiotics because of the potential neuromuscular complications. Do you like to briefly touch bases about complications like infections in the patient population in AFM?
And it goes back to the longer the breathing tube stays in, the higher the risk for ventilator-associated pneumonia. And, a lot of children with AFM may not need a tracheostomy, but if they get an acute pneumonia in this acute phase of illness, that may be the component that requires them to have a tracheostomy. So very diligent screening for new infections is critical, and aggressively treating them when identified. We don't typically put kids on prophylactic antibiotics or anything, along those lines. But, aspiration is a common thing. So I know some institutions routinely put children on clindamycin as a prophylaxis. We don't do that at this institution. But being very diligent to treat infections and not have that be the component that has them linger in the ICU is absolutely essential.
And I would add that I would think of an AFM patient different than a child who has a neuromuscular disorder that they've had for a long time and ultimately progresses to require mechanical support. Their entire physiology is a little bit different. So primarily for the AFM patients, we're worried about infection secondary to aspiration is probably the highest risk. And then they leave the unit and hopefully get better. They don't have sort of a chronic hypoventilation leading up to this intubation.
Thank you, Jessica. We are getting close to finish this question and answer portion of the symposium. But Leslie, I have encountered a couple of families of my patients that came with a question that is very interesting, is the repeating the dose of IVIG after a first initial trial of 5 rounds of IVIG, and attempting to repeat that a couple of weeks later. And some of those families are actually questioning the possibility that the IVIG actually may be helpful with consecutive doses. Do you mind touching base about that question?
Sure. I think in the acute setting, IVIG may be doing 2 things: calming inflammation, adding antibodies to help fight infection. But those are pieces of the acute syndrome, and I don't have any reason to believe that long-term, over many, many months, that the patients are having high levels of inflammation, and certainly they appear to clear the infection very quickly. And so I don't see a good rationale, and I haven't seen a benefit, and I haven't used ongoing IVIG in any of my patients.
Great. Thank you so much, Leslie, Becky, Jessica, for this great presentation.
Thank you.
To move to the stage, we are going to move back to the stage. So just please go from session area in your app to the stage area. Thank you.
Thank you.